Dr. Efshar has been an excellent resident. He took a little different path to medicine and residency. He came to this country with his family when he was 2, lived in New England, and went to Syracuse University, graduated with a degree in business administration, and had no thoughts, I think, about medicine in terms of a career. He actually worked at Random House Publishing for several years, did well there as an executive, but realized his passion was medicine. But he had to go back to college to do his basic sciences. He went to UC Berkeley. Then for medical school, he also had to really reach, he did a program with the University of Queensland and Ochsner Clinic, combined program, and came to Louisville in 2018. And he's been a great addition to that. When he graduates next year, he will move with his wife and 3-year-old child back to New England to be with his family for the first time in 20 years. He'll certainly be missed, but I know he will be successful in whatever career path he follows. And the reason I know that was because for his 3rd year, I was his long-term psychotherapy supervisor, a very enjoyable experience. We met almost weekly. And when you meet weekly with somebody, you get to know them fairly well in terms of their strengths as a psychiatrist. And Dr. Efshar, as everyone knows who is in the program and on the faculty, is a very nice, likable person, has a very high emotional IQ, and is very empathic. He establishes rapport very easily. He listens, is respectful to patients. And I mean, these are traits that you want to see not only in a resident, but in a very good and competent psychiatrist. And I never had to worry about him establishing a therapeutic relationship, an alliance with patients. Sometimes you have to work with people to tweak that, but for him, that came very easily. He also had a very good knowledge base to start with, but was eager to learn. So when we talk about reading assignments, he was always on the ball. He always had done them and reported back. And so we both learned from that. He was flexible when we looked at different approaches. He was open to that and very conscientious, always tried to do the best he could to help his patients. So I know he will be very successful. His topic today is typical of him: thoughtful, interesting, hedonic tone, an introduction to anhedonia without diagnosis. So I'm eager to listen to that. So let me go ahead and say, without any anhedonia on my part, it's a pleasure to introduce Dr. Saba Efshar.
Thank you so much, Dr. Weinstein. I very much appreciate that. And this is the first of the PGY4 grant rounds. It's an exciting thing to do, and a little bit of a victory lap, maybe a little premature on my part since it's a bit earlier in the year. But I do want to thank everybody in the program who's influenced me as a psychiatrist, who particularly Dr. Weinstein, my other supervisors, the many attendings who I've worked with here, who you all know, and of course my peers, particularly my PGY4 class, to sharing ideas within our field has always been just as important and educational. But I guess without any further ado, we'll go ahead and start. I do want to say thank you for attending. I know being remote is always a little bit harder. It's a little bit harder for me to be excited as a presenter. I hope I don't drone on. I have never met Dr. Weinstein in person, even though I feel very close to him and I can ask him for advice. But it's the current state we are in. So let me go ahead and share the screen here. Okay. So the topic I selected for today is hedonic tone and understanding the symptom of anhedonia independent of diagnosis. Now, our objectives for today are going to be to identify the clinical importance of anhedonia, independent of diagnosis, as I mentioned, and understand the neurobiology of hedonic tone and its role in psychiatric disorders, and then to re-examine the assessment and treatment of anhedonia, kind of what are the clinical applications of this presentation. And just to break things up a little bit, you'll see a few of these comics. This is Garfield without Garfield. It's somebody once started to remove Garfield from Jim Davis's famous comic strip, and kind of created a whole new material. So it's funny and at times poignant, and hopefully it will the color will give your eyes a rest from the rest of the presentation at times. Okay. So anhedonia, when I hear the word anhedonia, I think of memorizing my mnemonics for USMLE. As we know, it is a key element in our DSM MDD diagnosis. Most people consider SIGI CAPS as the mnemonic of choice for major depressive disorder. And in that interest, or anhedonia is included. I, of course, went to med school, or at least at the University of Queensland in Australia. And in Australia, the preferred mnemonic is A Sad Faces, which you may be familiar with, which is, like many Australian things, much more sensible. First of all, it includes all 9 symptoms of major depressive disorder as defined by DSM, unlike the 8 that SIGI CAPS encompasses. Oh wait, no, there's 9 in SIGI CAPS. I take that back. Forgot the S. But also it lists anhedonia as just straight up A for anhedonia. And so what does it mean? Of course, anhedonia is one of 2 of the key elements in the DSM-5 diagnosis of MDD. We have depressed low mood or anhedonia have to exist to achieve the diagnosis of major depressive disorder. Depressed mood has a general definition of sadness, feeling anxious, worry, frustration, anger. We can kind of encapsulate that as the idea of dysphoria, a state of unease or general dissatisfaction with life. Anhedonia is, as translated into English, is a lack or absence of pleasure. And the DSM-5 notes it as markedly diminished interest or pleasure in all or almost all activities, most of the day, nearly every day. You kind of see that it's trying to fit it in with its own diagnosis of MDD. What's important, I'm gonna have to move this. Okay, so what's important is that anhedonia is independently a predictor of outcome in depression. So in 2 kind of key landmark studies, one is GenDep, which, if you're not familiar with it, is the genome-based therapeutic drugs for depression, which kind of looked at antidepressant prescription records, I believe in the UK, to explore common genetic factors and antidepressant treatment resistance. But importantly, we have a whole wealth of data from that. And what in that data, it showed that there was a strong effect of anhedonia that was independent of mood, and that mood did not carry additional predictive information on outcome. And in the STAR-D study, which hopefully you're more familiar with, there's a higher baseline anhedonia score significantly predicted that worse outcomes of treatment on all three of their scales that they're either symptom monitoring scales that they're used, HAM-D being probably the one we're most familiar with in our practice. And this is even after it corrected for baseline severity. So of interest, they both of these studies looked to correct for any kind of confounding elements, but anhedonia persistently showed through that it was a good measure of, or a good predictor of outcome. And this is a graphical representation of that. And you can see it's a pretty linear correlation in both studies, that remission rates, according to HAM-D, the Hamilton scale, was significantly less in this fifth, this one study labeled as the fifth quintile for people with the worst anhedonia scores. So if they're in the bottom 20% or top 20%, depending how you look at it, of anhedonia scores, they were significantly more at risk for not achieving remission in these landmark studies. And it's, I mean, if you look at it, if you're in the top quintile, you're at 65% remission rate, and the GenDep, and in the fifth quintile, you're at 25%. So there's a significant spread there. And similar in STAR-D, we're at 55%-ish in the first quintile, and somewhere around 30% in the fifth quintile. And then when it comes to predicting suicide, again, anhedonia, independent of depression, seems to predict suicidal ideation and just overall suicidality, as it is referred to in many of these research papers. When looking at this inpatient population of anhedonia, I believe there's about 1,500 individuals or inpatients who are recruited for this. There was found to be a robust, their word, predictor for suicidality, and they used kind of a subscale from the version 2 of the Beck Depression Index, which I'll show you in a second. And it's important to note that this predictor for suicidality held true even when it also was corrected for baseline suicidality, whether somebody has chronic suicidality, and also when accounting for cognitive symptoms of depression, such as hopelessness. And that's something I think innately you would think hopelessness and suicidality might correlate. It might be a good predictor, but what was found out was that anhedonia was a much better predictor for suicidality. And the subscale in the Beck Depression Index is really just consisted of these 4 questions out of the 21 questions, I believe, in that assessment tool. And it does pretty well. And what's very, I think, useful and interesting is the loss of interest question includes its relationship to people. So it's not just people withdrawing from hobbies or not going to places they used to go to, participating in activities, but it's also losing interest in others, which might kind of account for somebody's suicidality. And, you know, in the week of Dr. Beck's passing, I don't think it takes a PGY4 to tell you that Dr. Beck knew what he was doing. And what's also important here is that a lot of studies will use loss of energy in the subscale, which of course is can be a separate symptom of depression, but it is thought to often be confounding for anhedonia. The people with anhedonia and low motivation will complain of not having energy as well. So that is why it is also included. All right, to further prove this point, a meta-analysis was done in France that also investigated anhedonia in individuals with and without suicidality. And I think a lot of these patients were recruited out of emergency rooms, I believe. Unsurprisingly, probably, the level of anhedonia was higher in the group with current suicidal ideation than in the group without. I don't know how much that quite tells us, but after controlling for depression and other psychiatric disorders, associations between anhedonia and well, oops, associations between anhedonia and current SI remained significant. And then I think when there was actually no difference in overall depression scores, what could predict SI better was the level of anhedonia when you compared the makeup of those scores head to head. So again, we are showing that independent of depression, of other symptoms of depression, anhedonia seems to be a better predictor for outcome and for SI. So let's, take a step back. We're talking about anhedonia kind of driving or being a predictor of these things. But of course, as everything in psychiatry, it's always a little bit more complicated. There's a whole biopsychosocial model to consider. Is the association between anhedonia and SI related to maladaptive coping? There might be a tendency to avoid unpleasant emotions. By an individual who starts to use these kind of strategies to avoid unpleasant emotions, a person might begin to distance themselves from noticing or appreciating pleasant events or experiences. They might stop engaging in what would otherwise be value-oriented actions. And then avoidance of these pleasurable experiences, these positive experiences, can dampen pleasant emotions and can exacerbate unpleasant ones, so worsening depression. And as I was mentioning, the personal component in the BDI subscale is that the researchers in a lot of these studies noted that the association between current SI and anhedonia was related to the social component of anhedonia, so that loss of interest in people, lacking a belonging to anything. And then furthermore, a loss of interest in people may also indicate of a person who is at particular risk of losing the ability to find meaning or purpose in their life, or a reason to go on living. So while we are, the whole is anhedonia driving it, it might be a predictor, but there can be a lot of other factors that worsen outcome that predict SI. And of course, things get more complicated. Some studies have found that relationships between SI and anhedonia are less significant in adolescents and young adult. That's pretty much suggestive of other likely social factors. And of course, I'm asking the question, is there a neurobiological trait that can drive anhedonia, which is naturally leading? That is part of why we're here to discuss that. First, we'll take a little bit of break. get some water for myself. But I do want you to read these quotes from literature. I did work in book publishing, so it's always a part of my life. And I want, in the real world, in the clinical setting, these might be the statements that you hear that are suggestive of anhedonia. I will spare you reading them out myself. These are two very good writers and two very good books. And we will hear more from them later. Okay, at this point, we'll start getting into the neurobiology of hedonic tone, the title of our presentation. And it was really the paper that kind of led me to this topic many, many months ago. And what I actually meant to say up top, I'll include it in here, is I became interested in this whole idea because there seemed to be a very significant subset of people I saw in the outpatient clinic who had this anhedonia, not psychomotor retardation, but just really lacked ability to gain pleasure, to predict actions that would lead to pleasure, a strong sense of apathy. And I noticed that patients with history of substance use fell into this camp more, and patients with ADHD seem to correlate with that. And so that's kind of where I first began to notice that, just in my own patient population that I was seeing, and I began to research it further. But anyways, so that brought me to this paper, the neurobiology of hedonic tone, and it looks at this idea of hedonic tone, or a genetic predisposition to feel pleasure. And the idea of this is that you are defining a lifelong characteristic or establishing a baseline range of hedonic tone. And somebody with low hedonic tone, which is the interest we have in this presentation, is somebody, an individual with a reduced capacity to experience pleasure. And this has been identified in several psychopathologies, including major depressive disorder, not surprisingly, since anhedonia is part of the diagnostic criteria. It's noted in substance use disorder, it's noted in ADHD, and it's noted in schizophrenia, which we are going to set aside in this presentation, since that's a bit complicated and unlike the other three, and the research tends to focus on correlating low hedonic tone in these other three psychopathologies. And those, of course, with low hedonic tone have an increased likelihood of experiencing anhedonia. And it is, of course, important to note that there are variations of hedonic tone that can exist in healthy individuals. So it is a capacity measure, and that's important to remember. And this is just a very neat little graphic from that paper I was referencing of what low hedonic tone might look like and what might one do with low hedonic tone. So it can be theorized that individuals who have a genetically lower set point, or as we are saying, low hedonic tone, will need more activation, will need more stimulation to feel euthymic or neutral. And it might manifest itself in these kind of internal or external pleasure-seeking or activation-seeking activities. Externalizing, we think of, risky behavior, self-medication, things that bring pleasure, whether it's drugs, which I think self-medication is referring to, even food for those with poor relationships with food, as well as internalizing. And this is fantasy, kind of daydreaming, these things that sometimes are associated with ADHD in young patients. And so patients with this trait will continually look to find ways to cope, to improve their mood. And if they lack this stimulation, then those with low hedonic tone are hypothesized to experience a shift down back to their baseline low hedonic tone level, which in essence is a drop in mood and puts them at risk for depression and their baseline dysphoric state. But again, just because you have anhedonia does not mean your baseline hedonic tone is low. And that, again, variations in tone can be normal. And those with low hedonic tone may never suffer from MDD or other psychiatric disorders. That it, again, is a discussion of capacity. And again, to bring back that psychosocial model, there's a lot of other influences, but this is almost a seed and soil argument, that if your soil is may lead to a depressive state more readily. Okay, and so getting a little bit into more of the details of the neurobiology and the proposed neurobiology of hedonic tone it's pretty much based on the mesolimbic dopaminergic system, which classically is called the reward system, and it is the neurobiological underpinnings of anhedonia. And the reason why is it's thought that to anticipate reward and to have positive reward feedback is ultimately what we are talking about when we are talking about pleasure. There's a little bit of an Easter egg for any book nerds out there in that statement. So when a lot of our neurobiological research links mood, reward, and motivation into the same reward circuit, that they all kind of stem from the same place, even if clinically we might be talking about things that are a little bit different. And in more detail, what we are talking about is the limbic, cortical, striatal, palatal, thalamic circuits. I'm going to drink some water, please. The main pathway, this is the main pathway that modulates emotional affect. Again, it's implicated in mood, reward, and motivation. And if you look at this kind of rough schema of the pathway, we're not going to go into any of the details here, but if you're familiar with the mesolimbic dopaminergic system, it's hard to tell at first glance if there's any difference, and that is purposeful. But research is more and more detailed in its look in this system, and different components of this pathway that are involved in the regulation of hedonic tone, which is what we are seeing in this slide. And I think an important thing to note here is that dopamine doesn't necessarily correlate with pleasure. I think classically, or in the lay world, that's the shorthand of understanding what dopamine does in your brain when it comes to reward. But neurobiologically, dopamine is activated before pleasure feedback is received. And it is thought that dopamine is actually there's an assigned importance to environmental stimuli associated with rewards and with increasing reward-seeking behavior. Essentially, it is helping you make decisions. What are you going to pursue, and how are you going to interpret the response to what you pursued, any feedback of anything you've obtained because of your pursuit? Is that are you receiving pleasure? So in that context, you kind of understand how the reward circuit functions and where anhedonia might come from this. If you are not seeking pleasure, if you are unable to seek pleasure, then your hedonic tone is dysregulated. If you can't experience pleasure after seeking it, then your hedonic tone is dysregulated. That's why there's this neurological or neurobiological link that is argued that the reward pathways is linked to the clinical manifestation of anhedonia. And I just want to point out some of the areas here. Again, I don't want to just list out all these things because I know in this setting, we're not going to retain any of that. But you can see that some areas that we are going to talk about, such as the anterior cingulate cortex, which is a working memory, and its associated subgenuate singular cortex, or the subgenuate anterior singular cortex. It's almost like a working memory for what they refer to as emotionally laden options. So things that you know have been positive or negative in the past, you have a working memory for. Now, your ability to access, to sort through this memory might be implicated in the regulation of hedonic tone. Your, of course, orbital medial prefrontal cortex, as well as the ventromedial prefrontal cortex, other prefrontal cortex sites are associated with this as well. And then just quickly, because I feel like we're already having our eyes glazed over, but the nucleus accumbens and the striatum are key elements as well, especially for reward feedback processing. And down here, something I think we're all more familiar with is this whole circuit is, the whole reward circuit is regulated by familiar monoamines. This is a bit simplistic. I think we know that glutamate and GABA have important roles in this as well. But for the common medications we use, it's good to kind of see this visualized here, that serotonin is thought to, it drives to decelerate the circuit. Dopamine will drive to accelerate the circuit, and norepinephrine helps with changing focus, so running through options and things like that. And so as we're talking about monoamines, we have this hypothesis of, or this classic hypothesis of depression. Of course, we're moving away from that now, is that depression is driven by decreased modulating function of serotonin, dopamine, norepinephrine. But of course, it doesn't really account for treatment-resistant depression, which is significant. In STAR-D, 30 to 35% of patients never achieved remission, despite getting treated with particularly serotonergic medications, and some included dopaminergic and catecholamines as well. And there's also, from STAR-D, we also have this poor long-term outcomes for any patient who required more than one treatment, more than a monotherapy, so more than just serotonergic agent. I think citalopram was their starting medication. So again, I think this is good timing for this pop of color. And of course, more recently, we are seeing a move beyond the monoamine hypothesis. And we're investigating into other neurotransmitter systems. And what we are seeing in that is that these other systems are altering structures in the LCS PT circuit or that reward circuit that regulate hedonic tone. And how does it do that? In our ketamine studies, we see that a single infusion not only reduces anhedonia scores, but neurobiologically, it increases the glucose metabolism in, I believe this is the dorsal anterior cingulate cortex, as well as the putamen. And in endogenous opioids are beginning to be looked at based on the idea that buprenorphine and samidorphin exert antidepressive effect by restoring hedonic tone and altering prefrontal cortical circuitry. It's a with opioids, we get this reduction in hedonic response to positive stimuli and reduce neural activation in ventrolateral prefrontal cortex. So a better understanding of the effects of these agents on the neural circuits that regulate mood and hedonic tone may be an important strategy for identifying new effective treatments of depression. So that's where the endogenous opioids come in, is if one has low activation in those areas, the ventrolateral prefrontal cortex in particular, is it a deficit of endogenous endogenous opioids? With the buprenorphine and samidorphin, we see improvement, but of course, a lot of people who use the improvement in anhedonia, but of course, a lot of people on buprenorphine have already altered their pathways because of substance use. Acetylcholine has also shown effect in the reward circuitry. Scopolamine has been studied, and there's been an increase in neural activity in the subgenual anterior cingulate cortex, and so that correlates with improvement in depression, and of course NMDA glutamate. But I did not include any options because I thought we might have already lost some people running through this here. And then research is also showing that there's research is also investigating the regions of the brain that regulate hedonic tone specifically. And there's a very interesting, small but significant study that uses fMRI to analyze what they refer to as trait anhedonia, or genetic anhedonia, which we are referring to as hedonic tone. And they found that it was inversely related to anterior caudate volume, but positively related to ventromedial prefrontal cortical activity during the processing of positive information. So what's particularly interesting about this study is that it used non-clinical individuals. So people with no history of neurological or psychiatric illness, no history of substance use disorder. And they were given this, one of the scales of anhedonia, which none of them are all that great, which we'll get into, but it was the revised physical anhedonia scale. And the idea behind that is that it evaluates one's ability to experience pleasure from physical stimuli. The obvious ones are like food, sex, but a lot of the questions on there are true false questions that ask you if the beauty of sunsets are greatly overrated, and I have always loved having my back massaged. So these assessment tools are often more fun than ones we are more used to, which is ironic given that it's trying to measure anhedonia. But what it is showing essentially is that there are people with lower capacity, or trait anhedonia, or low hedonic tone, whatever you want to call it. So patients without diagnosable psychiatric disorders show these neurobiological differences while scoring lower in an anhedonia scale, or higher in an anhedonia scale. I forget which way this one's actually scored. Other studies have shown that higher anhedonia scores have a decreased, that individuals with higher anhedonia scores have decreased nucleus accumbens volume, which might reduce pleasure feedback, and in interpreting pleasure feedback, as well as decrease resting activity in, again, the anterior cingulate cortex, which is helping in that decision making or the motivation to make a decision to obtain pleasure. So, to reiterate, low activity of the various components of this LCSPT pathway increases the likelihood of developing anhedonia, and then MDD, and then, of course, treatment-resistant depression. We're kind of building up to this. And you can see how treatments for treatment-resistant depression support this relationship. And before we get into that, I do want to highlight that the author is Sterner and Katzman of that paper, The Neurobiology of Hedonic Tone. They support their work with several neurobiological research papers. I think it was over 12, that all show this relationship of dysfunction in LCSPT pathway resulting in depression, anhedonia, as well as comorbid conditions, which we'll get into. So it's a very well supported pool of information, and it's been researched for over 10 years now. So we've talked about the relationship of anhedonia and treatment-resistant depression, that it is anhedonia is a predictor of treatment-resistant depression. In a very interesting ECT study, interesting for me because I am very interested in ECT, but the study showed that the treatment responders showed neuroplastic changes. There was a global increase in accumbens volume. There were local changes in other structures, the caudate, the pallidum. I stutter on that word a lot, so excuse me. And these neuroplastic effects of treatment are responsible for positive response to treatment. So patients were assessed before receiving any ECT, and they were found to have smaller baseline, this is patients with treatment-resistant depression, and they were found to have smaller baseline accumbens and palatal volumes against healthy controls. And then what also was found was that baseline volume and shape metrics predicted overall response to ECT with up to 89% accuracy. So what does that actually mean? So people who were clearly had these I'm forgetting how they refer to it. These neurobiological, these structural abnormalities, if you want to say that in comparison to healthy individuals, what could be noted as low anhedonia or low hedonic tone, excuse me, responded better to ECT, were better responders because the neuroplastic effects targeted these areas that are implicated in regulating hedonic tone. So it's a very interesting relationship between not only what was found, but the ability to predict who is going to benefit from ECT based on their findings. Other treatment-resistant depression interventions support this relationship as well. And vagal nerve stimulation, improvement in depression was associated with a decreased activity in the ventromedial prefrontal cortex and this cingulate cortex and an increase in activity of the superior temporal gyrus. And then in deep brain stimulation after 6 months of treatment, blood flow into these two prefrontal cortical areas among responders increased to levels observed in healthy controls, while the blood flow in the anterior cingulate cortex decreased, and that is associated with treatment of depression, that low blood flow in those prefrontal cortex or hypoactivity in those prefrontal cortices and increased activity in the subgenual anterior cingulate cortex, which they're looking at specifically, are consistent with patients with depression. So an improvement when improved depression, again, is supportive of the idea that areas in the brain that regulate reward improve mood. So implying, we are now, applying neurobiology of hedonic tone beyond major depressive disorder. So the impairment of reward-related processes and motivation in ADHD. I'm sorry, I kind of lost my train of thought there. Oh yeah, so we see that hedonic tone can be implicated in the impairment of these reward-related process and motivation in ADHD, because that's essentially what we're talking about when we're talking about hedonic tone. And a neuroimaging meta-analysis that looked at patients with ADHD found that neural activity within the frontostriatal area, as well as the frontal parietal circuits, were dysregulated in patients with ADHD. So particularly the frontostriatal area is implicated in the reward circuitry, and it is a common feature in ADHD. In adults, people with co-occurring MDD with ADHD have more prolonged symptoms. They're more likely to result in suicidal behaviors and hospitalizations. And that is significant, given that what was found is that in this paper by Gardner and others, that there was hyperactivity in the frontal regions associated with depression in these patients with ADHD that did not exist in patients with MDD and without ADHD. So there was another process, another specific process in the comorbid condition that they were finding. And they're creating this argument that this is a subtype of major depressive disorder, given the differences that they found in the neuroimaging. And one can argue that what we are seeing is implication of low hedonic tone, or implications of low hedonic tone. And in addiction research, it considers low hedonic tone to be one of the risk factors of substance misuse, since what is well known is that addictive substances, which include opioids and alcohol, work by raising hedonic tone. Of course, you would think that stimulants do this as well, but many substances do that. People who have become dependent of heroin, they report that they at some point stopped using heroin to just get high, but they also need it to get straight, to return hedonic tone back to normal levels, to return to euthymia. And of course, we know that chronic use of addictive substances are known to alter hedonic tone. The reward circuitry that links the ventral tegmental area, the nucleus accumbens, and the pallidum, they are all implicated in substance use, and that these circuits the substance use impacts these circuits and kind of create a hedonic dysregulation. Anhedonia is also positively correlated with drug cravings in those that have detoxified from alcohol, opioids, and tobacco. The more cravings that you have, the anhedonia seems to have some kind of relationship to that. And are we seeing substance users who have this low hedonic tone naturally as their, you know, their baseline trait that drives that? You know, we do want to look at the shared role of monoamines in all three of these conditions. The neurotransmitter studies reveal that depressed patients with MDD or ADHD have similar abnormal dopamine and norepinephrine signaling that leads to decreased striatal activation. So this is signaling by these monoamines within the reward circuitry. And we find that with methylphenidate, we can normalize hypoperfusion of prefrontal areas, and it corresponds to improvement in ADHD symptoms. This is in support of the dopaminergic theory of ADHD, where there are dopamine deficits, particularly in the frontal cortex and striatum, which again are implicated in the reward circuitry or a low hedonic tone. And of interest to this argument as well is that methylphenidate's ability to elevate dopamine levels in the striatum is attenuated in alcoholics. So alcoholism or chronic alcohol use alters dopamine pathways. And is there a desire to change dopamine pathways because of low hedonic tone as well? Okay, so ends our foray into the neurobiology. I'll start to tie all of this together, but again, this is a capacity discussion, and their variations can be normal. So it is not an argument that low hedonic tone necessarily needs to be treated outright. And again, we got good quotes from the same two authors. All right, so despite the importance of anhedonia, that has been well established, we have limited quality assessment tools, and even the definition of anhedonia itself doesn't really lend to the complexity or the biological underpinnings of what drives anhedonia, the reward processing, motivation, or impulsivity that anhedonia is related to. And some of the current assessment tools we have are the Snaith-Hamilton Pleasure Scale, the Dimensional Anhedonia Rating Scale, which by research seems to be the most reliable and valid, though even I believe the data for that is not the best. I think if I was to choose one, I would take the Snaith-Hamilton Pleasure Scale, because taking a pleasure scale over an anhedonia rating scale sounds much more fun. And it's much more whimsical. One of the questions I like from the Snaith-Hamilton scale is, this is not one statement that you're responding to, is I would find pleasure in the scent of flowers or the smell of a fresh sea breeze or freshly baked bread. That is poetic in its own right. And then, as we have discussed, some of these other papers use subset of already well-established MDD assessment tools. I don't know how well validated those are, and oftentimes there's, like we saw with the BDI tool, that is only consisted of 4 questions. And another limitation, of course, is that assessments are limited to active symptom monitoring, not a lifelong accounting of kind of baseline traits. So most depression scales measure, recent feelings and recent changes in the experience of pleasure or interest, and not changes from baseline necessarily. But this is kind of vital if we want to find an assessment that is going to incorporate evaluating low hedonic tone. PHQ-9 is probably our most widely used in our clinical practice, and it probably has almost no value when it comes to highlighting or trying to evaluate for hedonic tone. So why is assessing for anhedonia important at all? Why should we make effort to do this? Well, we can identify comorbidities and intervene early. As previously discussed, MDD is comorbid with, when comorbid with ADHD, it's associated with a more severe course, lower social functioning than with MDD alone. And MDD, ADHD, and substance misuse all share characteristics of low hedonic tone and underlying neurobiology. There may even be a subset of patients who are at risk for some of these things, some of these psychopathologies or substance misuse that we are categorizing incorrectly. Literature reports that co-occurring depression with ADHD is, depending on what you're looking at, it ranges from 9 to 50%, which again, given the increased severity of symptoms, that's important, especially if we're looking at, the 50% mark. But that's hard to know when a range is that wide, what we're looking at. STAR-D found that approximately a third of patients with MDD also have a substance use disorder. Are we misidentifying people with MDD who have low, as simply people with MDD, but they actually have this low hedonic tone and puts them at risk for other things? And then, ultimately low hedonic tone is a possible predictor of comorbidities in mood disorder and worse outcomes. Defining anhedonia is important. As I've mentioned, we don't really have a great definition. Our DSM-5 definition is really tied to the diagnosis of MDD itself. And it's hard to really get a good assessment without a good definition. A lot of the neurobiological research is really arguing to focus on decision-making as part of anhedonia instead of simply mood. And it can be referred to as decisional anhedonia, which can make sense. You stay in bed, you don't want to do anything because you don't have any ability to anticipate reward from any decision you're making, or get good feedback from any decision you do make. So you can divide that process in the clinical symptoms into two clusters. One is noted as consumatory anhedonia. So this would refer to deficits in hedonic response to rewards. And the other is motivational anhedonia, or a diminished response to pursue rewards. Those are two very related but distinct symptom profiles. And particularly with motivational anhedonia, you can see that treatments we have might be able to address that a little bit easier. Decisional anhedonia. So what is this model? What is the impact on treatment? Well, one is medication. So as I was just mentioning, this is where Treadway and others in their paper feel that dopaminergic medications should be used in these patients with depression who, particularly motivational anhedonia, is their primary trait. And this would be psychostimulants, dopamine agonists, both of which I would argue not all clinicians necessarily have a lot of comfort prescribing, particularly psychostimulants outside of an ADHD diagnosis. And of course, bupropion, which is commonly used. And so that might be a good first line or easily translatable treatment for patients who you might suspect have this motivational anhedonia as a driving symptom of their depression. Psychotherapy, of course, is important. Despite being a neurobiological paper, they really highlight the importance of psychotherapy here. And it is found that behavioral activation works the best, even better than CBT. And I don't mean to say that, and again, in the same week that Dr. Beck has passed away. However, behavior activation did come from CBT, but it's, of course, is its own branch of therapy now. And the specific techniques in behavioral activation address symptoms of decisional anhedonia, such as helping individuals to not wait to do things until they, quote unquote, feel like engaging in a reward activity. It encourages them to circumvent that impairment. And neurobiologically, behavioral activation shows changes in the reward system. So there is evidence both clinically and biologically in an improvement with behavioral activation. And then further impacts on treatment. There is a noted poor effect of serotonin reuptake inhibitors in patients with low, who are thought to have low hedonic tone. A well-known complaint of SRIs are emotional blunting, indifference, low energy levels, which is the opposite of what you want in somebody with depression. The best predictor of comorbid ADHD and depression who go on to have treatment-resistant depression is the number of SRIs failed specifically. Not all antidepressants failed, but specifically the number of SRIs failed. So why is this the case? Well, it turns out that SRIs are a poor choice to treat anxiety, depression and anxiety in patients with low hedonic tone, because it's been demonstrated that it diminishes the neural activation of the striatum to both aversive and rewarding stimuli. This might be helpful in anxiety in somebody without low hedonic tone. For somebody with low hedonic tone who already is functioning at deficit, this is going to make these side effects occur more readily. And it also may be related to inhibitory effects of serotonin on dopamine and norepinephrine through their activity on the serotonin 2C receptor on dopamine and the 2A receptor on norepinephrine. And we know that these symptoms are dose-related and reversible, so they are driven by the increase in serotonin. So again, people who are already at deficit, when you increase serotonin and kind of exacerbating the deficit, that's where these symptoms arise. But of course, I am only talking in context of low hedonic tone. I think it is easy, especially for us young hotshot psychiatrists coming out of residency, to kind of disparage SRIs out of hand, but there's plenty of data for efficacy of SRIs, including neurobiological evidence of serotonin dysregulation in depressed individuals, and you do see people do clinically improve on serotonin as well. So there is a role, but in the context of low hedonic tone, we use it as a first-line treatment, but it might not be an appropriate treatment, which again is kind of the purpose of this presentation. We see, when we continue to talk about treatment, we see that acute administrations of catecholaminergic antidepressants increases what's called positive affective processing. So it's the ability to measure speed in, it's the measurement of speed in responding to positive self-relevant personal adjectives, to recognize positive facial expressions, to access memory for positive information quickly as well. So these changes, what's interesting with that is, so you give the catecholaminergic antidepressants, and the improvements are being objectively observed, but the individuals don't rate changes, improvements in their mood or anxiety till later. So they don't necessarily note it themselves. So it's almost like a reverse of what we're talking about with poor outcomes of patients with anhedonia, that it's almost like a canary in the coal mine, where anhedonia is improving, somebody still feels impressed, but you know in some time they are going to improve, their depression is going to improve. And anecdotally, I've actually seen this a few times in ECT treatments, where families or a patient will even report that, oh yes, I went out with my friends, or I called my friend, or I went for a run, or I did this thing, I went to work, but they still report depression for a few more weeks, and then they have significant improvement. I've again, that's anecdotal in my own experience, but it's a very interesting phenomenon. And anhedonia again becomes almost like the canary in the coal mine in those situations. And then, of course, we talked about treatment-resistant depressive options and why specifically they work. They may work well for people with low hedonic tone, given the targets of those treatments. Okay, so let's tie it all together. We're wrapping up here. There is significant and reproduced research that identifies a neurobiological regulation of hedonic tone and of anhedonia, and that's via the reward pathway. And anhedonia is a predictor of outcome independent of diagnosis. We saw this with SI as well, that anhedonia and current suicidal ideation predicts current suicidal ideation independent of depression. And of course, that's highly relevant for our practice and potentials to intervene and improve suicidal risk detection or therapeutic strategies for prevention. Comorbid conditions with low hedonic tone have worse outcomes, and that there is a limited precise definition and limited assessments for identifying low hedonic tone in clinical settings that would otherwise lead to hopefully early interventions and to dictate treatment and really get our patients better faster and without incidents. So I guess at this time we will go to some questions and answers. I'll just quickly flash through the references. You can see that all of this is pretty well supported. And I guess I will stop the screen share to make this easier. Okay. Let's see. Q&A. It says, for ECT study for treatment-resistant depression, did it mention an average number of ECT treatments that were needed to see those results? The answer is yes. There was definitely a endpoint defined. I know that they did some of the neurobiological studies to measure the volumes and I forgot what they call the volumetric assessment of structures prior to any ECT. I don't recall off the top of my head what the average number of ECT treatments were, but it was in line with standard of care. It wasn't, yes, I'm sorry I can't give you a specific number, but it was clinically relevant. Any other questions?
Hey, Saba, great talk, by the way. It's in your experience, if you take our patients with treatment-resistant depression versus general depression, have you found the difference in patients' hedonic tones in terms of not the strict definition of treatment-resistant depression, like it has to be like 3 or more like medicines, but just in general, like you've tried a lot of things, mood stabilizers, et cetera. has not really improved them. Have you found a difference in those difficult patients versus the relatively simple patients?
So, in clinical experience, I think there's what I think of from my probably somewhat limited experience is that there's almost two different, when you're talking about treatment resistant to patients or people who come in who've been on many medications and don't seem to get better, there almost always seems to be two camps. There's those with what we would call melancholic depression or the anhedonic driven depression, people I would suspect with low hedonic tone. And those would be the patients you would refer to ECT, who kind of meet in ECT literature, who you kind of can predict would have good outcomes. The other camp is probably what used to be called like a neurotic depression, people who are highly anxious, and that drives their depression. And, interventions like ECT don't often work well or as good for patients with the anxiety element driving their depression as well. So, and that might be because the improvements you see aren't related to the same reward pathway. That what is the dysfunction in somebody with a anxious element of their depression might not be suffering the same dysregulation.
And to kind of follow up on that, you mentioned some neuromodulation stuff in terms of DBS, VNS, ECT. Didn't mention TMS specifically. Is there not enough data out there for TMS specifically for those kind of things, or?
I didn't go looking for it because the amount of papers I had stacked up was unwieldy as it was, and there wasn't a lot of reference to TMS in the papers I was looking at. A lot of these like meta-analyses, these neurobiological papers, they refer to ECT, they refer to VNS, and they refer to DBS somewhat frequently. I don't recall TMS that was mentioned enough that I started to pull other papers regarding TMS. And I just didn't want to go down another rabbit hole, or not a rabbit hole, but just make this presentation even longer necessarily.
Well, that's kind of an interesting observation, though, right? Because
yes.
DBS is not at all, like right now, at least, standard in any sense of the term standard of care for treatment of depression at all. In fact, there's the most recent meta-analysis is like actually showing it's not that efficacious, actually. So it kind of, I'm wondering if there's, at least in terms of the treatment for anhedonic depression, if that's like a quasi-bias to a certain degree, depending on the writers and their affiliations. Because TMS is an established treatment in depression in psychiatry. DBS is not at all.
So that's a very good point, and that a lot of this information, obviously there's a lot of clinical information that was presented that came from pure psychiatric sources, but a lot of neurobiological data is produced by neuroscientists. So that kind of, as you were saying, there is a bias towards like something like DBS, interest in DBS, because it's a very researchable topic. There's a lot of research done on that topic. You can do a lot of imaging studies based on neuroimaging studies based on that as well. So yeah, you're probably right. There probably is a bias towards it, and then it's also as far as TMS is concerned, that typically you're hitting the prefrontal cortical area of the brain. So I think there's also a bias that's only hitting one region of this reward pathway. It might not be worth investigating quite as robustly from their point of view, whereas these other interventions might you can catch more elements of the pathway.
Well, DBS specifically targets just one nucleus usually when they place it. But what's interesting from a separate perspective is, which is important for the junior residents and anyone interested in research to also know about, is that a lot of universities, their breakdown in terms of how the departments are structured, usually a neuroscience center is run by neurosurgery, just because neurosurgery brings in the most money, research, and clinical dollars into the center. So for example, the KNI, the Kentucky Neuroscience Institute down in UK, its head was Dr. Philip Tibbs, the chairman of neurosurgery at the time. And so a lot of that, so there's also an inherent desire to kind of further neurosurgical research dollars in psychiatric illnesses, just because there was a huge trend for that earlier on. So that's very interesting that you noticed that in the literature with the neuroscience research specifically. And I think Arthur had a question, by the way.
How do we throw it to him?
He typed it in on the Q&A. So he said, is any evidence linking depression with psychotic features to specific depression subtypes, neurotic versus anhedonia/melancholic? In my own limited experience, most patients with depression and psychotic features seem to be primarily melancholic.
I did not explore that. And I think a lot of this information, psychotic symptoms were left out purposely because we're talking about potential treatments with dopaminergic medications and things like that. So it would be potentially not wise to do that when they're in that state. I would not be surprised. I think what you do see, what I did come across is that melancholic depression is frequently associated with worse outcomes and more severe symptoms, which again would psychotic features in depression would fall into that. Do you plan to use any of the inventories questionnaires specifically for anhedonia that you mentioned? Potentially. I mean, the BDI being able to subscale, I think actually in one of our other resident discussions, Dr. Faruqi mentioned the benefits of the subscaling of BDI. So that's a potential, but I think, you know, clinically you can tease out to know how to ask questions to really evaluate for anhedonia, and especially when we're talking about the decisional anhedonia properties, not, you know, are you doing the things you used to do, but really drilling down and seeing why are they not feeling benefit from it? Do they not, or when they think about it, it's just kind of hard for them to muster any motivation to do it. And I think that it's that kind of line of questioning might be more revelatory based on this information than how some of these scales ask about losing interest.
I guess Saba, from based on your kind of research on this, is there? I mean, we talked about. I think we talked about this a little bit during our Chiefs Hour discussion. But are you going to lean towards a specific scale for depression in your practice in the future?
Yes, and I think the more I read, I think the BDI version 2 might be the most useful when you're trying to really organize a formulation of what is driving depression. You know, I think when it comes to determining if somebody's depressed or not, you don't need the scales to do that. So something like PHQ-9 is unnecessary. And for a psychiatrist, maybe a screening tool for primary care, it's more beneficial, and for billing and insurance purposes, maybe it's useful. But as far as our psychiatric practice concerns, I don't need PHQ-9 to quickly diagnose depression. You can find those 9 questions, you can get those answers pretty easily. I think when it comes to really formulating what is driving depression, what are the symptoms that this patient is truly suffering from or has most issues with, and I think sometimes maybe something like BDI can help with that. They can, or at least begin to point you in the right direction, and then you can use your robust interviewing skills to tease out what might be showing positively on those skills.
Yeah, I completely agree with that. I think the BDI-2 is actually one of my favorite skills as well, because it can actually help drive treatment because of the subscaling that we had talked about previously, and you mentioned as well. What's interesting is I have seen attendings here and also in research purposes use PHQ-9 as a quick and dirty way to show patients who are anhedonic that they are actually improving, to kind of instill hope to a certain degree. And I've seen that a little bit in our specialty clinics here too. They're like, which is, there's a margin of error there of plus or minus 2 to 3 points, I think, in my opinion, but it's still, I've kind of, I've been playing around with that as a tool to kind of show the patients themselves, like, hey, look, you are getting better. Just hang in there. You make adjustments, et cetera, et cetera.
Yeah, and I would wonder what is driving that depression. What is the, if we want to say subtype, what is the subtype of that depression? Because I find in ECT patients, I will give PHQ-9s, which can show improvement. But as I was saying, sometimes I found that people seemed like they were improving, even though they weren't reporting improvement themselves. So it was kind of hard to use a tool like that to be like, where they're assessing very little change or to no change, where everybody around them is like, oh, wow, he's coming out of his room. He's going on runs. He's getting back to himself or herself. I think subtyping depression, I think really not using a one diagnosis for as kind of like an overarching diagnosis for all these nuanced symptoms is probably the biggest takeaway.
Yeah, definitely going back to the phenomenology of things. I think actually here I had a question too. So if you're any association between trauma and low hedonic tone?
Nothing I looked at included that. Maybe there is a potential argument you could make that you are more prone to chronic symptoms of trauma because of low hedonic tone. I didn't see anything that specifically looked at that. Obviously, with trauma introduced, you have something beyond neurobiology that is affecting things. But whether you have this, we talked about seed and soil, whether your soil is more fertile to kind of develop these long-lasting symptoms could be argued, but I don't have any research to back that up. Okay, well, if there are no other questions, it's almost 1 o'clock and ending time. Anyways, I just want to thank everybody for listening and thank all those involved with my education and development here at University of Louisville. Thanks, of course, they're not going to hear this, but I should say it anyways. Thanks, of course, to my wife and to my parents, who really have a very interesting and remarkable story. If you ever want to talk to me about it, it will be a fun hang. But thank you all.